Order, order. The committee is back in session. I'm very pleased to welcome to our second panel of witnesses Dido Harding, Baroness Harding, who is the interim executive chair of the National Institute for Health Protection. Thank you for coming today. And her colleagues who are joining us virtually. We have Dr. Susan Hopkins, who is the chief medical advisor to NHS Test and Trace, and Simon Thompson, who is the managing director of the NHS Test and Trace app. Thank you very much indeed for joining us this afternoon. Perhaps I can start with a few questions for Baroness Harding. Starting with, what is the current capacity of the diagnostic testing system?
So as we stand today, the capacity for both NHS testing, which we call Pillar 1, and the National Testing Programme Pillar 2 stands at 242,817 tests.
Why has that not been
per day.
Why has that not been published since the 10th of September?
That is being published at 4 o'clock today, as I understand.
Why was the gap? They were published all through the summer, but mysteriously they stopped on the 10th of September.
We have worked really hard over the last 4 months since I arrived to make sure that we validate the data that we publish. So from time to time we are double checking and making sure that as this organisation grows really fast and adds in new data feeds from new labs, we make sure that the data is accurate. That was the only reason for the pause.
Something went wrong that you had to put right?
No, it was simply a question of validating the data and making sure that we weren't putting data into the public domain that wasn't accurate.
It was all right.
Internally, the NHS used constrained and unconstrained capacity. Which capacity are you referring to?
This is total capacity. So if you'd like the split between the two, the NHS capacity, the Pillar 1, as of today is 82,817. That's for the UK. This is all 4 nations. And Pillar 2 is 160,000.
And they will be published every day now?
Yes.
Yes. Still not entirely clear why there was this period this week in which, for the first time, they were taken off without explanation.
Just simply a question of validating data. Remember how fast this is growing. So just for context, on Monday the 7th of September, the total was 226,773. So we're adding new capacity all the time. We just need to make sure that the data feeds are accurate.
During the days of this week, has the total capacity gone up or gone down?
Yes. So on Monday the 14th, it is only, I think, Wednesday today. On Monday the 14th, we stood at 231,921. So we've added 10,000 capacity in the last 2 days.
That's increasing?
Yes.
Okay. Now, so what is the current level of demand for tests?
It's quite hard to give you an accurate figure of the level of demand because, it's clearly obvious there is significantly more demand than there is capacity today. So the best way we have of estimating the total demand at the moment is the number of people calling 119 and the number of visits to the website. But that's not going to be a completely accurate, it's a proxy.
You must make an estimate, I assume.
Well, we make an estimate, but the number of people calling 119 and visiting the website would be 3 to 4 times the number of tests that we currently have available. But there will be some double counting in that. People will call from their home line and then from their mobile.
If you're managing the system, you must have a view of what the real demand is and what the capacity is. What is your estimate? Leaving aside people having to call multiple times because they can't get through, strip that out. How many people want to test? Then we'll relate that to how many tests are available.
I think, it is multiples of the total test capacity we have today. Bearing in mind the question you asked, Chair, of what is the demand, the number of symptomatic people who should be coming forward for a test will be significantly lower than that. What we have got, and we know this from surveys in our testing sites, that up to 20-25% of people who've been coming forward for a test don't have any symptoms.
When you say coming forward for a test, in order to register, you have to have symptoms, do you not? In order to be given a test place, if there were one available, you have to report one of the 3 symptoms.
We ask people to confirm that they have one of those symptoms.
So how do you know that 25% of people actually have registered for the test but have no symptoms?
Because we've been running some surveys outside of our testing site. So after you've registered and you've then turned up at the testing site, and we've asked people whether or not they do actually have symptoms. And we surveyed, so if I give you the details, 24,000 people at 25 regional and local testing sites between the 1st and the 4th of September. The Secretary of State referred to this earlier today, and this data will be published online. 27% of people said they were there because they'd been in contact contact with someone who had tested positive, but they didn't have symptoms themselves.
Okay. In order to be there and to have got to the test centre and to be allocated a test, they've had to declare that they've had symptoms. So you're saying 27% of people lied?
Well, I completely understand why people are worried and scared and coming forward for tests.
That is what you're saying, that 27% of people lied about their symptoms.
I'm not. But our local testing sites, you don't need to make a booking. You can just walk up. So some people will just be walking up to get a test because they're worried, because a colleague or a family member has tested positive, and it's totally understandable.
They wouldn't be allocated a test. They'd be advised that they needed symptoms to have a test, would they not?
They ought to have symptoms.
So that's not a demand on the test. They're not using tests. They wouldn't have been given the tests in those circumstances.
Generally, if we have people walking up, having either booked a test or asking for one, are brilliant people who are manning the hundreds of testing sites across the country, don't want to push away people who are scared. But we do have a significant number of people who are coming forward for tests who don't have symptoms.
Why have we had this sudden increase in demand? I think you'd agree that there has been an increase in demand, I assume.
Yes, there has definitely been a substantial increase in demand. I think that Professor Hannigan and the previous witnesses in your earlier session referred to some of this, which is that it's an entirely human thing to be scared and worried and to then think that the answer is to get a test. And so, if I, again, give you some examples, a restaurant owner contacted me yesterday where one of their staff had tested positive, and they then asked all of the staff to go and get tested. Whereas actually, unless they had symptoms, they really didn't need to be tested.
That could happen at any time. There's no reason why September has seen this increase in demand.
I think again, as Professor Hannigan pointed to, I think with all of our children going back to school, we've seen a very marked increase in the number of young children coming forward to be tested. So a doubling of the number of children under 17 coming forward to be tested, and more than that in the ages of 5 to 9. And again, I think, as I say, I completely understand this. I've got children at school myself. The temptation is one of your children has a temperature, they need a test, but then the rest of the family gets tested as well.
We knew the children were going back to school in September, did we not? It didn't come as a surprise.
And we planned for a sizable increase in testing capacity. As I've just described, we've been adding testing capacity every day, every week, over the course of the last few weeks, in anticipation.
But not enough.
Well, plainly,
by a multiple factors.
As the Prime Minister said yesterday, plainly we don't have enough testing capacity today, and we are doing everything in our power to increase the testing capacity.
One of the reflections this committee has made, and our purpose in conducting these inquiries, is to learn lessons that can be useful for decisions further down the road. And in the early days of testing, lots of decisions had to be made very quickly, and it's understandable that not all of those were the right ones, and there's no particular blame that can always be attached to that. But we did establish, I think, a consensus that we ought to have anticipated the need for increased testing and to put that in place before the Secretary of State made his personal commitment to surge it during April. And so it's dispiriting to find that we're now in September in circumstances which are entirely predictable, that people are going back to school, people are going back to work, and we haven't had the right capacity put in place during the quieter times of, say, June, July and August. Why didn't that happen?
Well, actually, I don't think that's true. So at the end of May, we had 128,000 tests a day capacity. Today we have 242,000. So it's not been a quiet summer for NHS Test and Trace at all. We've doubled the size of our testing capacity, which is exactly what we committed to do. And we're on track to double it again to 500,000 tests a day by the end of October.
During the month of April, the Secretary of State increased testing from 1,000 a day to 100,000 a day, a 100-fold increase. What seems to be apparent is that you haven't prepared for the increase in demand that has transpired. It may have doubled, it may have increased, but it hasn't surged to the extent that was done before, and clearly ought to have been done for September. Why wasn't that the case?
Well, as I said, as the Prime Minister said yesterday, plainly we do need to expand testing capacity. And I really understand the frustration and worry that people have who are trying to come forward for tests.
Is there a problem with the assessment of demand? Are we going to be able to have accurate predictions or assessments of what demand will be in the future?
Could I just answer the previous question? So we built our testing capacity plans based on SAGE modelling. We published our business plan at the end of July, and we are absolutely on track to deliver that. So we're doing everything in our power to bring that forward. But we will have, and I would say that today we have more tests per 100,000 population than any other major country in Europe. We have in total tested more people per million population than any other country that has been hit badly by COVID other than Israel.
I do understand that, and so you've made a very important point. So the capacity that you have created has been the capacity that SAGE told you was needed at this stage?
Yes, we built our capacity plans based on SAGE modelling for what we should be preparing for the autumn.
That assessment was SAGE's rather than NHS Test and Trace?
Yes, indeed.
Okay. So the capacity is going to be increased to 500,000 a day, we understand from the Prime Minister.
Yes, that's correct. By the end of October, we will be able to offer 500,000 tests a day.
Will that be enough?
Well, I am certain that we will need more as we go beyond the end of October. And we announced this morning 2 further laboratories that will be opening, one in Newcastle, one in Berkshire. Those laboratories won't be on stream by the end of October. So we are already laying the foundations for expanding capacity beyond the 500,000 at the end of October.
You must have made an assessment, it would be necessary to make an assessment as to whether the 500,000, insofar as you can project it, have you set that because that's what you expect demand to be by the end of October?
We've set it as those were our plans, but as I said, Chair, it's clear from today that demand is significantly outstripping the capacity that we have. And so we are all going to need to work on this together. We do need to make sure that we protect the testing capacity we have for the people that most need it, which means that people who have symptoms are the people who should be coming forward to be tested.
Just in terms of that future demand and the future capacity, now we know from scientists on SAGE that the number of people in the population that display COVID-like symptoms during an ordinary winter, when COVID is not present, is 500,000 a day. So the capacity that you'll have by the end of October is only enough for the coughs and colds that people have normally. It actually doesn't address the extra demand that comes from a pandemic and perhaps the extra concerns and sensitivity that people have that they may notice symptoms more if they know that COVID is around. Well,
and as I said, we have plans to go beyond the 500,000 a day, and we announced openings of new labs today that will contribute to that. And our work on capacity building beyond the end of October is based on, again, clinical and scientific modelling of what the country should need in a winter season rather than a summer season.
I see. Go to Dawn and then to Mark.
Can I just come in on one vital point on this? How do you measure total capacity? Because the Prime Minister has said that there was a 375,000 capacity. You've now told the committee today that there's a 242,817 capacity. That seems to be a reduction in the capacity that the Prime Minister said. But how do you measure the capacity, and do you need to revise how it is assessed?
The figures I've quoted you are antigen testing. The figures the Prime Minister was quoting are combined antigen and antibody testing, so they're completely consistent.
Right, so it's 2 different.
Clearly you didn't prepare enough for the schools coming back and people going back to work. The fact that the end of October was the target date to have this capacity in place, was that because you expected a second wave, as it's sometimes called, to be in October? Has it come earlier than you expected? Is that the problem?
Well, I think that I don't think anybody was expecting to see the really sizable increase in demand that we've seen over the course of the last few weeks. So none of the modelling was that expected. And that's why I say I think we all have to think really hard about how we prioritise the use of these tests. That we're clear that you should only get tested if you have the coronavirus symptoms, if you've got a fever, that you've got a new and persistent cough, or that you've lost your sense of taste and smell. And so we're all going to have to play our part in managing the constrained capacity, even as we double it and keep going beyond that.
That's been the guidance for months now. The rationing is within people that have symptoms, that certain people with symptoms won't be able to access it for the time being.
As I said, right? We see quite a lot of people coming forward who don't have symptoms, who and I really understand why you would feel like this, who want to believe that if they get a test, they won't need to self-isolate, that if one of their family members has tested positive, that if they get a test, they won't have to isolate with them. And sadly, that isn't how the virus works, and it isn't the medical guidance.
If you strip that out, you still don't have enough capacity. The Secretary of State this morning said that people would need to be prioritised amongst those that have symptoms.
Yes, and we're very clear on our prioritisation. So, firstly, we're prioritising support for NHS clinical care, NHS patients. So we test hospital patients, including all admissions. That's the number one priority. Well, our number two priority, and again, Professor Hannigan referred to this, is to protect those in care homes. This is the one group of people who we're testing who don't have symptoms. We know that the best way we can protect those of us, our loved ones living in our care homes, is to make sure that we regularly test care home workers and residents and all new admissions into care homes. So of our testing capacity, roughly 50% of our testing capacity goes towards NHS clinical care and testing in social care. And that's before we...
So hospital patients, social care, what's the next priority?
NHS staff, including GPs and pharmacists where possible. Mm-hmm. That's the third priority. And actually, sorry, I misquoted. Let me get that right. The three priorities of NHS patients, social care, and then NHS staff make up about 50% of the total testing capacity today. And then below that, once we move to testing the general public, community testing, we are prioritising additional testing capacity for outbreak areas. So we look to make more mobile testing units, to have more tests in local testing sites for areas with very high disease prevalence. And then finally, the broad general public, where we are looking now, given the very large demand, to prioritise within that key workers, particularly teachers.
Is there a hierarchy within key workers?
Well, as I say, we're just currently working on that. But as many people have said, prioritising education, and particularly teachers, so that schools can remain functioning, would be likely to be top of that list, though the work is still ongoing.
I'll turn to Mark Logan now, but just to be clear, so 50% of the capacity you expect to be taken up by NHS patients, NHS workers, social care workers.
As of today, that is 50%.
The remaining 50%, first of all, will go to outbreak areas. As of today, what proportion do you expect to be consumed by that?
Well, if I could answer the question slightly differently, on average, across the country, we are testing in each local authority at a level of roughly 100 people per 100,000. Mm-hmm. And in our outbreak areas, we are testing at roughly 2 to 3 times that level. That's the way we look at it.
That remaining 50%,
yeah.
What proportion of that 50% will be mopped up by the outbreak areas?
I haven't got that figure in my head. I'm really sorry, because the number of outbreak areas changes from day to day and week to week. So I can share that with the committee.
This evening when you get back out,
I can share
let the committee know that, and therefore what the residual is for the other key workers.
And I should there is one other element of testing that runs underneath this, which again your previous witnesses mentioned, which is the programmes we have, the surveillance programmes we have, the research programmes, to make sure that we understand the prevalence of the disease, the ONS and REACT surveys.
That's not useful in isolating and treating.
No, but it is using testing capacity, and it's important that it does.
Mark Logan.
Baroness Harding, I represent Bolton North East, which is at the epicentre of the pandemic and has been for the last 2 weeks. Testing isn't working in Bolton. How can we have confidence that what's been happening in Bolton will not be the case for the rest of the country?
Well, I appreciate the concern and worry about testing capacity everywhere, and particularly in areas like Bolton where the disease prevalence is so much higher. But yesterday we did 1,093 tests in Bolton. Over the last 7 days we've conducted 6,968 tests. The last 14 days, 13,179. And as I say, that's roughly 2 to 3 times more testing than we're doing on average in the country. So while I do understand that everyone wants to have the maximum number of tests available, we are doing our utmost to prioritise within that allocation of the general public testing in Bolton and in the other areas of higher prevalence.
But I can't say to my constituents that we're doing our utmost whenever, for example, the first mobile testing centre that was launched last weekend in Bromley Cross, my constituency, was full of errors. It didn't go to plan. Again, what are we doing to make sure this doesn't happen in other parts of the country?
Well, we are rolling out more and more testing capacity every day, and we're also broadening our distribution network every day. So, if you sort of step back and look at the scale of the testing platform that we've built, we are on track to have 500 different testing locations across the country by the end of October. And particularly in areas such as Bolton, we are deploying more mobile testing units and also opening more walk-in testing sites in our inner cities, making it easier for people to access testing. So that is all in the plan. We are accelerating every bit of it as fast as we possibly can. We are all working day and night, 7 days a week, to try and deliver the testing capacity that the country needs.
Mark?
But are you finding that these mobile testing units in other parts of the country, like what's happened in Bolton, have the same problems? So, for example, the testing centres have capacity to test one person every 5 minutes in Bolton. However, whenever they were first opened, we're only averaging 3 per hour.
Yes, the reason for that is that the constraint in our end-to-end testing system is in the processing in the laboratories. Actually, the footprint that we are building, the 500 different local testing sites across the country, will be able to scale up more and more as the processing capability grows. And we have to restrict the number of people who are taking tests in the testing sites so that there's no risk of those tests going out of date when they're processed in the labs. So I do understand how frustrating it feels that when you arrive in a testing site and it doesn't look like it's very busy and you can see it could do more, but the capacity constraint isn't in those testing sites, it's back in the lab. And it would be very dangerous to send too many samples back to the laboratory, have them not be processed and people not know what their results were. So that's why we have to restrict the demand where we all come to get tested.
My last question is just people from Bolton, they can't get a test. A lot of people can't. Have been contacting me both on social media and by email, but they're saying that those living outside Bolton can get a test in Bolton, or indeed if they put in a postcode for Wigan, for example, then they can get a test in Bolton eventually. What would you say to that? Should people just turn up as a walk-in service?
Well, we've been making changes and learning and improving with each passing week. And one of the things we've done over the last 10 days is to reduce the geography that you can book a test in advance. We make our local walk-in centres open for people to simply walk in for exactly the reason you're describing, to encourage the sort of local residents. And we'll continue to work with places such as Bolton to see how we can ring-fence more of the testing capacity to our most high-risk areas.
Thank you, Baroness Harding.
Removing that capacity from places of comparatively low risk to high risk, I assume.
Yes, and that's done at a local authority level, at a regional level and at a national level. So we work very collaboratively with the local authorities and with the regional public health teams in Public Health England to deploy the mobile testing units based on prevalence and outbreaks.
Is it the case that you told the Chair of London Councils that there will be a 20% cut in London's testing capacity?
So the London testing capacity, just against some figures, yesterday we tested just under 10,000 people in London. We're averaging circa 10,000 a day. And London's testing capacity, tests per 100,000 per week are slightly above the national average. And as a result, over the last few weeks, London has seen the absolute number of tests allocated come down, precisely because London has a lower prevalence than Bolton and other areas in the northwest and now in the northeast.
Is that 20% figure accurate?
I'm sorry, Chair, I don't have that with me.
Afterwards. Let's turn to Dawn and then Carol and then Graham.
Thank you, Chair. Thank you, Baroness Harding. I mean, it is quite ridiculous, isn't it, that there were no tests available in COVID hotspot zones. Out of the 10 top COVID-19 hotspots in England, there were no tests available, and people were sent, far away when they had testing centres on their doorstep. But my question to you is, how do you define the capacity? How do you work it out, the capacity?
Well, first, it's not that there are no tests available in our hotspots, quite the opposite. There are 2 to 3 times more people being tested in the areas of high prevalence than the national average.
But that's not actually the experience of people who are living in areas that are on lockdown, for instance. I mean, LBC conducted investigation into that. So that's not actually the case. And also, as you mentioned, that the facts are that, out of the government's capacity of 375,000 that they say they have of tests, the actual number of people being tested has stalled at just 437,000 people a week. And that was at the start of this month. So that equates to just 62,000 tests a day. So when you take what you say is the capacity and how many people are actually being tested, why is there a problem with testing?
I'm afraid that's not true. Today, 207,000 people were tested. Yesterday, 213,000 people were tested. On the 14th of September, so Monday, 213,000. On the 7th of September, 170,000 people were tested. So I'm sorry, I don't know where your numbers come from, but these are the validated ONS-checked numbers of people who were tested.
Even on those numbers, it's still less than what you say you have as a capacity.
You will never run at exactly 100%. Actually, for a couple of days in the last week, our laboratories have run at over 100% capacity, which we're very concerned about, because these are large and complex end-to-end operations. So if you take our laboratory in Milton Keynes, it's processing over 30,000 tests a day. That's 30,000 packages that have a swab in it and your personal details that have to be physically unpacked, prepared, processed, put through the testing machine, logged back into your system.
So we understand that, the delay is with the lab and the testing. That is obviously quite clear, and it's quite clear that's why you're trying to delay people taking a test. Now, I know that there's a research institution that has lent some PCR machines. They're on loan to the end of the month, which I'm sure is included in your testing capacity. Do you have plans to extend the loans of these PCR machines? And if not, what will happen if those machines are taken back?
I'm afraid I don't know the specific example you're referring to, but if we look at our path from the 242,000 capacity that we have today through to 500,000 at the end of October, there are a large number of different elements that make up that path. So our existing laboratories are, as we speak, implementing more robots that unpack and prepare the tests ready to go through the PCR machines. That will I'll get there in a sec, sorry. That will expand that testing capacity.
The chair will not let me ask my other
there
questions.
are a number of laboratories across the country that we are adding into the network. That's acquiring more testing capacity. And then, as I've said, some of the larger labs that we announced a month ago or two ago are also coming on stream. So there's a whole range. I can't speak to your specific example,
any machines that are on loan, you will extend that loan so that you can continue to increase your
It's
capacity.
a mixture, because some of them might genuinely be needed by their universities, for example.
Can I ask you just about Randox, who won a £133 million testing contract unopposed at the start of the outbreak? They disposed of 12,401 used swabs in a single day on September the 2nd, and they also voided more than 35,000 used test kits since the start of August. The company has not denied charging the taxpayer for voided results. Can you confirm that the taxpayer is being charged by Randox for these voided tests?
You're referring to a couple of incidents that are still ongoing. So at this stage, I can't confirm or deny that. We are working through with Randox and with the MHRA to understand the root cause and what's actually happened.
Okay. Just sticking with Randox for a minute, up to 750,000 unused coronavirus testing kits were, as we know, taken out of the system because of safety standards. What were those safety standards? What was wrong with them?
As I said, that's an issue that is currently under investigation together with the MHRA.
Okay. And Randox employs the MP Owen Patterson on £500 an hour. Do we know what he does for Randox?
I'm afraid you'd have to ask Owen Patterson rather than me.
Okay. And just my last bit of questions, Chair. We're talking a lot about people taking tests who are symptomatic, but we know this is an asymptomatic disease and it spreads asymptomatically. And Professor Bell gave evidence to this committee, and he said that it is a largely asymptomatic disease, which means that you have to be careful about track, trace and isolate strategy that relies on symptoms because you will miss 70% of the people. How do you square that with the current strategy that you're employing?
That is exactly why our second testing priority is care homes. So we are running a very large asymptomatic testing programme where we test all care home workers in adult social care every week for exactly the reason that you describe, and why we place that actually as a higher priority than the general population symptomatic testing, because we've learnt from the last 9 months how this disease attacks the elderly and the most vulnerable in our society, and how it's really important that we protect them in a closed environment in care homes by ensuring the disease doesn't come in.
Instead of criticising people who maybe work in care homes who are going to get tests that are asymptomatic, we're going to start encouraging them.
I'm not criticising care home workers. I'm not criticising anyone at all. Care home workers receive tests once a week today and have done over the course of the summer, and we're very committed, the government's very committed to maintaining that care home asymptomatic programme for the reasons I've just said.
Thank you, John. I'll turn to Carol, then Graham, then Aaron. But just to follow up on one of the answers you gave to Dawn, in terms of increasing the lab capacity, you're building these new lighthouse labs. You're making use of other labs in this country. Are you making use of overseas labs as well?
Yes, we have a number of other labs, both in the UK and overseas, that we would deem surge capacity labs that we can bring on faster, and we are doing some of that as well.
What would be the capacity of those overseas labs?
A relatively small proportion of the increase. We're talking low order tens of thousands.
Thank you. Let's turn to Carol and then Graham. Carol Monaghan.
Thanks, Chair. And I was just wanting to follow that up with Baroness Harding. What is the ultimate target for lab capacity per day?
Well, 500,000 a day by the end of October, but we are not stopping there. We've already started committing to opening more labs and expanding capacity beyond that, but we don't have a formal target beyond 500,000 at this stage.
The figures you've quoted today in terms of daily tests are way below that. So, and you've talked about increases of tens of thousands. How are we getting to 500,000? I'm assuming we can't keep increasing by tens of thousands every single day. So how are we getting to 500,000?
So it won't be a completely linear journey of 10,000 a day, but what you will see is substantial increases every week between now and the end of October. And you'll see it from a variety of different programmes of work. So our existing labs, particularly our labs in Milton Keynes, in Alderley Park and in Glasgow, will be able to significantly increase their capacity as they implement these new robotic processing capabilities. The NHS, our NHS labs in NHS trusts across the country are also significantly increasing their capacity as they implement new technologies and new processes. We are adding in additional laboratories. So we announced a laboratory in Newport some 6-8 weeks ago. That will be coming on stream during October. And we're also adding an additional lab capacity from smaller labs across the country, across Public Health England and other universities. So it is a number of different initiatives that step by step very clearly take us to 500,000. And I would say that the testing team have hit every single one of their testing targets over the course of the last 6 months as they've grown this industry from 2,000 tests a day to over 240,000 today. So we're very confident that we will deliver on our 500,000 by the end of October.
Carol?
And what about the turnaround time? At the moment, there's a target of 24 to 48 hours. Will it still be that?
Yes, absolutely. Now, you are completely right that, and we have seen, in the spirit of openness, we have seen test results take slightly longer than usual over the last week or so, and the results that were published this morning, you can see that. So 64.7% of people who are tested face-to-face received their result the next day between the 3rd and the 9th of September. That is below our target of 85 to 90%. We have very consciously, in the last couple of weeks, when we've seen the very significant increase in demand, made use of every single day of the 7 days of lab capacity to try and maximise the total number of people that have been tested. And what that has meant is that for some people the testing turnaround times have gone out a bit. As we bring on more capacity over the next week or two, I would expect some of that additional capacity to go not to more people being tested, but actually to seeing those turnaround times reduce. It's a balancing act that we monitor in every lab across the country several times a day to make sure that we are maximising the number of people tested and trying to keep to those turnaround times.
And in terms of the symptoms, we've already had a discussion of symptoms. If people have a symptom, they have to get tested, or they should request a test. Surely we should be looking for 2 symptoms. If I have a dry cough, it doesn't mean I've got COVID.
Well, in this I would refer to Dr. Susan Hopkins, who's on the panel, as we take the clinical advice from the CMO, Susan and her colleagues, as to which symptoms and in what way we should prioritise testing.
I'm happy to do that, Dr. Hopkins.
Thank you. So we review the symptoms regularly and have reviewed the symptoms at least every couple of weeks since the start of this pandemic. Our most recent review a couple of weeks ago, again, looked at the 3 symptoms, and cough, fever, and the change in smell and taste were the 3 priorities. That will give us a rough sensitivity of about 80 to 85%. It won't pick up everyone, but it also gives a specificity of about 55%, which means that we're not testing anyone with one small symptom, but we're focusing on the people most likely to have the disease. We don't give a dry cough, a wet cough. We talk about it being a continuous cough. And the reason for that is that the cough can change over this course of the illness. And what we want to do is make something that was simple to communicate to the public. It still feels the right symptoms, and we've looked at both the Zoe app and other information coming out of ONS, React, and what they're finding on their surveys. And we feel like we've got the right sweet point for testing at the moment. We will continue to review that.
And it's still the advice, with one symptom you get tested?
It is, and we looked at combinations of those symptoms, but that reduces the number of people who would be eligible, and significantly would reduce the number of people who are the right people to get tested in the community. It would drop down our sensitivity markedly.
Okay, thank you, Chair.
Thank you. Just on the timing, it is the case that the Prime Minister promised in June that there'd be 100% turnaround within 24 hours. Isn't that the case, Baroness Harding?
Well, we have delivered next day turnaround times in the 80s to 90% through the summer. And as I've said, it has dropped down over the last couple of weeks. And that was a conscious decision in order to try and meet more of the demand. And I would expect to see the turnaround times improve as we increase capacity over the next few weeks.
Of the home testing kits, the figure is 9% turned around in that case within 48 hours, and 1 in 5, 20% within 24 hours at local test sites. So very substantially below the target that was set.
The 64.7% of next day turnaround I'm referring to is people who've taken a test in person. So whether they've come to a mobile testing site, a local testing site, or a walk-in site. You're absolutely right. The turnaround times for home testing kits have always been longer because the test has to make its way from your home. It's a slower delivery turnaround.
A test is a test. The purpose of the test is to contact trace and to inform where the infection is spreading.
And it is exactly why we've been opening more and more testing sites so that fewer people have to rely on a home test if they're feeling ill. The home tests are particularly useful for patients going into the NHS to get a test in advance of having an operation, where you're testing not to see if you have the disease, but make sure that you don't have it.
You're moving away from home tests as being...
Well, if you look at the mix, because we've opened so many more local testing sites and mobile testing sites, the mix is shifting to more physical face-to-face testing.
Is it a policy decision to prefer?
Yes, because the turnaround time will always be faster.
Earlier in the pandemic, in evidence of this committee, witnesses from Public Health England and indeed ministers talked very positively about the mass mailing of home tests as being a way in which you could improve the level of testing.
I think that at that point in the pandemic, as you say, when the testing platform was going from only 1,000 or 2,000 a day to 100,000 over the course of a very small number of weeks, it was entirely appropriate to be doing that. And home testing has a really important role in the overall testing platform. But if you've got symptoms and you're in the general population and you want to get a test result back straight as fast as you can, it will be faster if you go to one of our face-to-face testing sites, which is why we're opening so many of them.
Thank you. Graham Stringham.
I don't envy anybody who's got a senior position during this epidemic. But would you like to tell us how you became the acting executive chair of this new National Institute for Health Protection?
Of course. I didn't apply to do the job I'm doing at the moment. I was asked to serve by ministers. And I suspect, like everybody working on the COVID response, I felt it was the appropriate thing to do to serve my country and say yes to that request.
Do you think it's right, I know you've accepted the position, that you should accept a position without open competition, even though it's an interim job? It encompasses 3 previous agencies. It's a very important position. Don't you think there should have been competition? Because there's been a lot of criticism that your experience at Talk and in retail, which may have been fine in those areas, is not appropriate for this position.
Let's take a couple of things in that. So firstly, as you rightly say, this is an interim position and an unpaid position. And we've started the open competition to recruit the permanent appointment. And so, given that it's important that there is immediate leadership, regardless of whether it was me or not, making an interim appointment without open competition is the way to ensure you've got leadership immediately. So that's the process, not my decision at all. Ministers chose to take that process. In terms of the skills that you need to do the job, the skills that the team need, and this is a huge team effort, is clinical, scientific, operational. This is an enormous consumer citizen service with huge logistics and data analytics and data flow. And I've got an amazing team of people, and I'm not for a moment going to pretend I've got all of those skills. Of course I haven't. This is a team effort. None of us like talking about ourselves, but my experience is and all my working life is in large consumer-facing services. And I've got a lot of experience of retail and logistics, and I've spent the last 3 years as the chair of NHS Improvement. So while I am not a clinician and only have 3 years' experience, I do understand the NHS and the public sector to couple with my logistics, retail and technology experience.
With your previous experience in this area and the month you've spent as acting executive chair, what do you think this new body will do better than was done by the previous 3 agencies?
And just so I understand, sorry to clarify, by the 3 agencies you mean?
Public Health England, the Biosecurity Centre, and what was the other one that's been put into it? I've not got it.
NHS Test and Trace. Okay.
Yeah, just
so NHS Test and Trace and the Joint Biosecurity have been one entity since they both began. So that was the reason for just wanted to clarify. So the immediate benefits that we are already seeing is accelerating the collaboration and joint working. So the 3 organisations were working very well together, But it's been actually rather extraordinary to see how in the space of a few weeks, by knowing that our long-term future is together, it's encouraging professionals in the clinical, the scientific, the data analytics, the operational teams simply to work together faster. And in the fight against COVID, those small benefits in team working and problem solving can actually make a very big difference.
How would we measure that?
You'll measure that's a very good question. I think you'll measure that by our ability to act faster over a broader landscape. So, for example, I was today at the meeting, the Gold local outbreak management meeting chaired by the Secretary of State, which is a hugely collaborative process between the Test and Trace team, the Joint Biosecurity Centre and Public Health England. And in the course of the last 3 weeks, objectively, we have seen much broader coverage of the country, much more work done collaboratively, and a much clearer local voice because of the integration with Public Health England. So I appreciate that's not an output measure, but 3 weeks in, I probably couldn't give you an output measure, but we are seeing a much more integrated, and Dr. Susan Hopkins on this panel is a great example. Susan is a joint appointment into both organisations and is leading our clinical and medical team in the fight against COVID in the National Institute.
Can you just explain to me, because I'm genuinely not sure, what the relationship of the new body is to the Lighthouse Laboratories? Do you determine the contracts that are let out to the Lighthouse Laboratories? Do you determine their policy? Do you determine their day-to-day work? What is the relationship?
So the Lighthouse Laboratories are contracted by NHS Test and Trace, so by the
Effectively,
Institute.
you let the contract.
And we work very closely with those partners as they are increasingly implementing new technologies in order to speed up and expand capacity.
When Serco's contract was renewed over the summer, had they met all their key performance indicators?
There was a full and comprehensive review of the performance of all of our contact tracing suppliers, of which Serco is one. And the recontracting process was led by our commercial teams in normal government processes.
That doesn't quite answer the question, if you don't mind me saying.
I'm sorry, I don't actually have all of the KPIs in my head, and I'm very happy to write to you to set out.
I wasn't asking you to have them in your head. I just wondered if they'd met all of them.
I can't. The nature of good commercial management is you set your commercial partners a large number of challenging targets, and so the only reason I'm hesitating is that they might have hit 99% of them, and then I wouldn't be giving you a truthful answer. So that was all. But they have done a good job. They stood up a service very fast. And as we haven't talked about contact tracing at all, we have reached 350,000. Actually, no, sorry, it's now, from the numbers published this morning, 417,000 people, thanks to them and NHS professionals and local public health teams.
And what part of these contracts are public? I mean, you say that you will let us know what the assessment was. What level of detail will we get about these very significant contracts from the public sector to the private sector?
I will need to go back with my commercial colleagues and make sure that I share what is appropriate to share publicly, given that these are commercial arrangements. But obviously we would need to do that in full, normal, transparent process.
And if I may, I know I've had a lot. If I may have one last question. My view that some of the things that have gone wrong with Test and Trace and the whole response to COVID is that it has been too centralised, and that these lighthouse laboratories have over-competed to the detriment of many of the private and local NHS laboratories. What would be your response to that point?
I think that what we're trying to build is a local and a national system, and we need both. So the NHS and smaller university labs have done magnificent work in scaling up testing. Our local public health teams, both in local government and in Public Health England, have also done magnificent work. We need both. And so the model that we're trying to build is a local by default, but also a nationally supported. So we couldn't put on 250,000 tests a day extra capacity in the next 6 weeks entirely through the NHS. But the NHS is playing a huge part in that. Likewise, we couldn't have contacted 417,000 people in the last 4 months entirely through local action. We need both the national and the local. And what we're seeing increasingly, and particularly in areas like Bolton, Oldham, Leicester, Blackburn, real collaboration between local leadership teams and the national test and trace and joint biosecurity teams working together.
But nevertheless, the mobile laboratories were handed over to G4S, not to local authorities.
Well, if you mean the mobile testing sites?
Yes.
In order to be able to move them so that we have some flexibility.
We do want to come on to tracing and to contact tracing and indeed the app, but just to return briefly to the question of the turnaround of tests. The target that you're given by the Prime Minister is a 24-hour one, the 24-hour turnaround. The figures that you quoted to us were next day. So would you kind of give us what the performance of the system has been in the most recent figures within the 24-hour period against which you're measured?
It's quite a lot lower. I'm afraid I don't have the figure in front of me. The reason I don't is that a 24-hour turnaround time would mean we'd be measuring whether people get their texts and emails in the middle of the night. So from an operation... No, I'm just giving you the operational statistics that we measure and focus on have been the next day. Simply because that's a way of ensuring that people get that test in order to be able to go to work or go back to school.
Well, it's the figure is 33%.
Yes, as I said, I know it's significantly low.
2/3 don't meet the target of 24 hours, and the reason that's relevant. Firstly, it's the figure that governs your work. It's the figure that was given by the Prime Minister. It was in your report that was published this morning. But it's also the case that this is not a random number. SAGE has been very clear. Right back at the 1st of May, SAGE said that any delay beyond 48 to 72 hours before the isolation of contacts results in a significant impact on the R number. And obviously there is a chain there. So if you have a delay in getting a test, and then there is a delay in getting the results of the test, and then the time that it takes to trace those contracts, the smaller and smaller proportion of people who test positively and are symptomatic have their contacts being tested. In other words, according to SAGE, it drives an increase in the R number. So isn't it the case that the failure of the testing regime, which I hope is temporary, is driving the increase in the pandemic across the country?
I strongly refute that the system is failing. So, as I said earlier, we made a conscious decision because of the huge increase in demand to extend the turnaround times in order to process more tests over the course of the last couple of weeks. And whether or not you get your test results at 2 a.m. or at 8 a.m, actually our judgment, and it is a judgment, was that it was better to meet more of the people who were really worried and scared and wanted a test. We flex that across each channel and each laboratory, as I said, several times a day, 7 days a week. And as we bring on more capacity, I would expect those turnaround times to go down. But that is a balance. And the whole system is an end-to-end balance that is about us playing our part in expanding testing capacity, but it's also about all of us playing our part in only coming forward for tests if we have symptoms.
The committee has recognised and has called for the expansion of testing, and we're very supportive of the surge that took place in the spring. And so we recognise the efforts that have been made. So when I refer to the failure, it is the current failure, which it seems to me, if 2/3 of people are not getting their test results in line with the target, that is something that needs to be addressed. And let me put it this way. If SAGE say that you need to have the contacts traced by 72 hours, should you have a measure as to how that is being adhered to, given that Your organisation that has been formed now is responsible for the whole pathway, if you like, from testing people to identifying contacts. Should that 72-hour target, so as not to increase the prevalence of the disease, should that not be what you're judged against?
Well, we're judged by quite a lot of metrics, and we try to be as open and transparent as possible and publish all of them, as you know, each week. So we measure not just the turnaround time for testing, but we also measure and report on how fast we reach contacts. And we measure the percentage of contacts that we reach. So SAGE set us a number of other targets as well. They set us a target to reach 80% of people who had tested positive, and we reached last week 79.8% of those. We also set a target to reach 80% of contacts, and we reached 86.6% of contacts where we had the communication details of the people who were named as contacts. So you are absolutely right that end-to-end turnaround time is also important, but so is whether or not we keep everybody flowing through. So all of this is about balancing each of those different operational measures.
Let's go into that a bit more with Aaron Bell.
Thank you, Chair, and you've anticipated some of my questions there nicely. Thank you for your time, Baroness Harding. I did want to turn to tracing. We've focused a lot on testing, and rightly so. You just gave us some of the statistics. Taking it all in all, from the top, the people who were transferred to you in the first place, what percentage of their contacts overall, once you go through all the stages of contacting them, trying to contact them again where they're complex, what proportion of contacts overall do you estimate you're reaching? Not the ones that you're trying to, at each stage, but overall, what percentage of contacts do you estimate you're reaching from positive tests?
Well, it's hard to do that because we've got to estimate how many people our index cases have actually told us about. And so I'm hoping we're going to get a chance to talk a little bit about the app, because one of the big gaps in our measurement is people that you've been a close contact with who you don't know. Because index cases can only tell you, people who've tested positive can only tell you of the people they know. Whereas if you're an app user, that should significantly improve our effectiveness. So it's hard to actually answer your question because of that unknown.
But of the known contacts, I mean, if you're not reaching around, is it 17% of people in the first place, and a number of them you're not reaching their contacts because they haven't got the details or whatever? Does it end up being more like 50% than 80%? Is that a known contact?
I might defer to Susan on this, just because this is very standard for contact tracing. It's a well-tried and tested public health intervention for a whole range of infectious diseases. And while you're right that it's a percentage on a percentage on a percentage, that is how you break the chains of transmission.
Yes, of course.
And you're never going to get 100% at each stage. I don't know if Susan would like to
I
a bit more.
Will I come in briefly? So I think it's really important to recognise that in an ideal world, when an individual recognised they were positive, they would be able to know exactly who they had been in contact with in the previous time that they were potentially transmitting infection. What we know is that people who are coming forward, we're getting about 85% of people who come forward for contact tracing. The others don't answer their phones, don't answer emails. So there's very little we can do for those. In some local authorities, they started door knocking, where we've got postcodes for those individuals, but we'll never get 100%. Secondly, when they give your contact details, they can only, sometimes they may have the wrong phone number for an individual, they may not have the correct name, and we'll do everything we can to try and find those, again, including door knocking, where they can give addresses in local authorities who have initiated local contact tracing. But actually, all of this brings the sort of app into sharp focus, because what the app does is it doesn't matter whether you know someone's details, it's giving you an estimate about whether you've been in contact with someone, and being able to tell that other individual whether they're at risk and what they should do next. And I think Simon might be able to clear up exactly what the app is doing.
Okay, we'll talk about the app in a little moment. If I could just go back to Baroness Harding then. We obviously, you reach a certain proportion of people, and you obviously ask a number of them to self-isolate. What do you then do? Is that the end of the line as far as the tracing app is concerned, or do you monitor whether people do self-isolate, Baroness Harding?
So we have been conducting some trials over the summer to understand how people cope with self-isolation because it is really hard for a number of different reasons. So understanding what support makes a difference, what the triggers are that mean that people might not stick to it. We've been running a number of different tests of calling people or sending them text messages, and also making sure that they've got support from local government. And what we've learned over the summer is that it is actually very hard, and that most people try their best to do the right thing, but that they either have caring responsibilities, or they feel they need to pop out to grab something from a shop, or they just want some fresh air, and that a meaningful percentage of people find it hard to stick to that self-isolation during the full 14 days.
So you're saying that a large percentage don't stick to it completely. Are there some that disregard it altogether, as far as you're aware?
I don't have hard data for that, I'm afraid, but I think it's safe to assume that across an average there will be some people who don't, and that we need to really impress upon people that the way that we all get back to a more normal way of life is that if we are very high risk of being infectious, if we've been in close contact with somebody who tested positive, that we do follow the advice of NHS Test and Trace and we self-isolate.
And what proportion of the people you ask to self-isolate go on to develop COVID?
I don't have a statistic for that. And one of the reasons I don't is we don't test people who are in self-isolation, and we don't test them for two reasons, or we actively don't want them to come forward for testing for two reasons. The first is the nervousness that if you test negative at some point in your 14 days, that will be another reason to believe that you'd be okay to go back to normal life. Whereas, as I'm sure Susan can talk us through, unfortunately the virus doesn't work that way. So we don't test during self-isolation, and as we've described earlier, that wouldn't be one of our priority uses of testing. So I'm not able to give you quantitative data, though again my clinical colleague Susan may have more evidence than I. Sure,
but I understand the logic of what you've just said in terms of the impact on the individual, but from a scientific perspective, isn't it worth knowing whether self-isolation is actually keeping COVID cases out of general circulation?
Maybe if I could refer the question to Susan.
Okay, yes, please.
So I think what we know in looking at the case details is that the people who you're most likely to transmit to are your household contacts, and the next groups are those that you're in close contact with. We do look and try and match data from contact tracing to the testing records, but we don't find very many people who come forward for a test. But that may be due to the fact that many people have asymptomatic infection, and we've asked them to self-isolate for 14 days to prevent transmission to others.
Thank you, Dr. Hopkins. Baroness Harding, you understand where I'm coming from a scientific perspective here. The Royal Statistics Society has recommended improvements to this data, including random sampling, record linkage. Have you looked at taking those recommendations on board?
We are continually looking to improve our service, and remember how new this is. This scale test and trace service that is only 5 months old, and absolutely we are looking at continuing to understand how we improve our ability to break the chains of infection. And again, I'm sure Susan can talk to some of the research work that we are doing with academics and statistical partners across the country.
Thank you. It seems you acknowledge yourself, and I acknowledge that it's hard for people to self-isolate. And if we're aware that the most obvious ones who need to self-isolate are immediate family, it seems that only fair and sensible way to approach a pandemic that we're having to manage, we're not trying to completely eradicate, that we assess whether the kind of people we're asking to self-isolate, whether that's actually doing any good. And unless we have that information about whether those people ever had COVID, it seems we're not going to refine the system. Would you agree with that?
I think, as Susan has said, there are two things about this virus that are incredibly counterintuitive to a layman like me. The first thing is that it's counterintuitive to believe that you're most likely to catch the disease from your friends and family. It's instinctive to believe that strangers are more dangerous than the people that you live with, and yet all the evidence is your household contacts are likely to be the most likely people that you will either infect or get infected by. The other thing that is counterintuitive is a belief, we all want to believe that a test will set us free, that if we test negative, then everything's fine. And yet the way the disease incubates, that's just not true. A negative test on day 2 or 3 or 4 or 5 or 6 of self-isolation doesn't mean that you won't infect your friends and family at some point during the 14 days. And so we do know those two things. And Susan can give you the academic foundations. We do know that our intuition is not how the disease works. And if we are going to break the chains of infection and we are going to get back to a more normal way of life, we do need to follow the clinical guidance.
Thank you, Baroness Harding. I'll pass back to the Chair. We're short of time.
Thank you, Erin. I'm grateful for that. I'm going to invite the Minister, Lord Bethel, to join us to have some questions.